Let's learn about and review narrow regular tachycardias. What possible rhythms are there that can be narrow and regular? Well, sinus tach, very common. SVT, as we refer to it, which is kind of the jargon version as opposed to the technical definition. The technical definition of supraventricular tachycardia would be anything that's not ventricular tachycardia. But in the field setting and for ACLS and for National Registry and for all general purposes here, we're really talking about AV nodal reentry tachycardia or AV reentry tachycardia, and those are what we're going to call SVT. So I'm not going to say those others anymore. I'm just going to call it SVT. So that could be narrow and regular. It doesn't have to be, but that is one of the rhythms that could be narrow and regular. Sinus tach doesn't have to be narrow, but it is frequently narrow, and so that would be one of the narrow regulars. And I think the third one to consider, particularly at rates around 150, would be atrial flutter with 2-to-1 conduction. If atrial flutter, well, the atria like to flutter around 300 beats a minute. So if you have 4-to-1 conduction, your underlying ventricular response is 75, no big deal. If you have 3-to-1 conduction, your underlying ventricular response is 100, and that's usually not a big deal. But if, because the atria like to flutter around 300, then a 2-to-1 conduction, you're going to have a ventricular response in the 150s, and that could be certainly causing some problems because of the fast rate. And then obviously if you go to 1-to-1 conduction, now that's going to be extremely unstable. A ventricular rate of 300 isn't sustained for very long at all. If you were to see that, you would immediately cardiovert it. The 2-to-1 conduction isn't going to get immediate cardioversion. That person could be not unstable yet, or they might be unstable. But anyway, these are the three rhythms we're going to talk about: sinus tach, SVT. We'll talk about how to differentiate those two, and then A-FLUTTER. Again, if it is unstable, we're going to synchronize cardiovert it, but we're not going to cardiovert sinus tach. Sinus tach should not be cardioverted. You need to treat the underlying cause. We'll talk about those in just a second. The tachycardia in sinus tach is a response to something else, or it's compensatory for some other problem. Whereas SVT and atrial flutter, those are electrical conduction systems, cardiac electrical conduction system problems. And so SVT and atrial flutter, according to ACLS, would be cardioverted, synchronized cardioverted at 50 to 100 joules. We have chosen 100, but that way anything that's regular for us gets 100 joules. But you would be right in a National Registry testing scenario to say 50 or 75 or 100, anywhere between that 50 to 100. Remember, ACLS is a guideline. It's not a direction. It's not a protocol. It's a set of guidelines, and their guideline is somewhere between 50 and 100. You should be doing sync cardiovert on these rhythms, and we're trying to simplify things and as a memory aid. Anything regular would sync cardiovert at 100 joules, and that, if you refer back to our Tachycardia badge buddy card, then that matches up. Hey, so talking about sinus tach, we said treat the cause. Well, what are the causes? Well, a sinus tach could be compensatory for a patient who's very hypoxic, for a patient who's very hypoperfused, typically hypovolemic shock. It might be that the tachycardia is an attempt to make up for another condition. It's compensatory. It also could be in response to a patient who's under heavy exertion, a patient who's very scared, very angry, very hurting quite a bit. Could also be that they have taken some stimulants, a coke or a meth or something like that. So while cocaine and meth can certainly get you into high tachycardic rates in greater than 130, exertion can, as anyone who exercises and watches their target heart rate there, but just being scared or just being upset, just being in pain will usually not push that rate up much over 130, and I'd be surprised if that rate is really the cause of this patient's instability. If you think your patient is unstable and you look at their rate and it's 118 or 124, it just seems unlikely. It's certainly less probable that it is the rate that is the problem, and those are typically a sinus tach. All right, treatment of SVT, very different than sinus tach, so it's very important that we be able to differentiate SVT from sinus tach. Treatment of SVT is you pull these things out of your toolbox, and maybe in this order, at least the first three are certainly in this order. So an SVT is a problem in the AV node. It's a problem with chaotic conduction, reentry pathways, and circus sort of movement in the AV node. And so a vagal maneuver, such as a Valsalva, where you have the patient blow the plunger out of a 10 cc syringe, and that takes a long time, and that it takes strong effort, and that gets a good, strong Valsalva maneuver. And so that vagal maneuver may slow traffic through the AV node, and that's what we're looking for in tachycardias, and that may be helpful for you in SVT. It may convert the patient out of it. It may not. They may come out of it and go back in. Every patient's different, and so a vagal is an easy, quick, non-invasive thing to try while you're setting up for other things. Adenosine is a very effective treatment for SVT. It reboots the AV node, and hopefully then if you can just stop all activity in the AV node for a few seconds, then normal activity will take over and the chaotic stuff will be gone. If that doesn't work, then a calcium channel blocker can slow conductivity through the AV node. A beta blocker can do the same thing, and amiodarone can be effective in that way. Remember that amio is a tool that has multiple actions, and so it's got some beta blocker in it, some calcium blocker, some sodium channel blocker. And so amio can be effective for those as well. I think it takes a while for amio to be given, and it takes a while for amio to take effect, and so usually the adenosine is a real quick thing to try that's effective in a lot of cases, and if that doesn't work, then move on to a calcium blocker or a beta blocker. So differentiation of SVT from sinus tach. This is important because the treatment is different. And as I said, SVT is caused by a cardiac conduction issue. It's a reentry malfunction in the AV node. It comes on suddenly, like you're flipping a light switch on, and it pops into a pretty steady, fast rate that doesn't come and go and vary very much, maybe 2 or 3 points on your rate counter, but it's not like a sinus tach that may drop down 10 or 15 points as the blood pressure has increased, and then as the blood pressure continues to drop and the sinus tach goes back up, it varies. SVT is quite different. It flips on and sits at a pretty steady rate, and then we fix it by rebooting the AV node. Sinus tach, on the other hand, is a response to something other than the cardiac conduction system issue that's going on in SVT. It comes on gradually. Sinus tach comes on gradually. And so if you're going to think of SVT as flipping on or off like a toggle switch light switch, then again, to me, maybe this works for you, I hope it does, then to me sinus tach is more like a dimmer switch, where you turn up the speed of your fan or you turn it down, or you turn up the intensity of the lights or you turn it down as needed. And so the rate increases and decreases and is variable in comparison to SVT, where it pops into a fast rate and just stays locked in there. So how do you fix sinus tach? Well, you fix whatever's causing sinus tach. If it's a stimulant thing, a meth or a coke thing, those either wear off or you end up with beta blockers or something to deal with that. But we're not going to use cardioversion. We're not going to use vagal maneuvers. We're not going to use adenosine. If it's a hypoxia or shock caused sinus tach, if that is compensatory, then deal with the hypoxia, deal with the shock, and the rate will come back down. The rate's not the problem in sinus tach, is what we're saying. Where an extremely fast sinus tach can be causing its own problems in terms of myocardial oxygen demand, in terms of decreased filling time and decreased perfusion. I understand all that, but the sinus tach is caused by something else, and so we need to deal with whatever that something else is. Then what about rate? If you're trying to decide between SVT and sinus tach, there's somebody out there always telling you, well, SVT is 160 or more. And so that's sometimes true. In younger patients, that's true. But in older patients, that 160 number is just kind of pulled out of the air. And it made its way into teaching for some reason several years back. I was taught this. But it's been a long time, and things have progressed. And so we know now that a reasonable estimated predictable maximum rate for sinus tach in a patient is 220 minus their age. So a 20-year-old can get up close to 200, whereas a 60-year-old in the 150s, 160s. This is not a hard and fast rule. There's times when this is violated, but it's one of those things that you can use as a clue. There's not one thing you look at to differentiate SVT from sinus tach. You look at all the factors, and rate would be one of them. So putting it all together, we're going to consider the rate rule, and the rule is in quotes there. We're going to consider SVT to have a constant rate while sinus tach is going to vary. We consider the onset of SVT as sudden, and there's really no underlying cause, whereas sinus tach will have a cause. And then, again, this really matters because we are not going to use the same treatment. We don't give adenosine, vagal maneuvers, calcium blockers, sync cardiovert to sinus tach, and we do all those things if needed to SVT. So finishing up here with atrial flutter, we had talked about there were 3 rhythms that would show up as narrow regular tachycardias, a sinus tach and SVT. They spent a bunch of time on that. But let's don't forget A-FLUTTER. A-FLUTTER may respond to a vagal maneuver. If we can increase the conduction ratio, get it out of the 2-to-1 and get it more to our 3-to-1 or 4-to-1, then that may help, and that is really handled by the AV node. The reason the conduction ratio is what it is based on how permissive the AV node is being, how many impulses it's letting through. Adenosine's not helpful. If you mess up and give adenosine because you didn't realize it was flutter, it may slow down the ventricular rate enough that you can really see the flutter waves pop up. Atrial flutter at 2-to-1 is sometimes hard to appreciate the flutter wave, but atrial flutter at 4-to-1, everybody ought to see that. So you wouldn't intentionally give adenosine. You wouldn't do that as a diagnostic tool, but if it happens, then take advantage of it. Same with atrial fib, which we'll talk about later. If you mess up and don't realize that your tachycardia is irregular, and you think it's an SVT, and SVT is going to be regular, so you missed that it was atrial fib and you gave it adenosine, you shouldn't do that on purpose, but if you do, then you may see that it slows conduction down. So atrial flutter, it may slow it down a bit and it may go back up. Same thing may happen with calcium blockers like our favorite diltiazem, and it may happen with amio as well. Again, amio takes a while to give, takes a while to work. Diltiazem, same deal, may not be all that effective in atrial flutter, but A-FLUTTER easily cardioverts at 50 joules or even less. And the joke is sometimes they can even cough and cardiovert themselves out of atrial flutter. I don't know if that's a joke. It may actually be true. So realize that while we're going to use 100, it would be okay with us if you said, oh, well, that's atrial flutter, I'm just going to cardiovert them at 50. But it's a very effective, cardioversion is very effective with those rhythms.